Glad to be here. My name is Peter Edelstein. I'm a colorectal cancer and a trauma surgeon by trade. I spent many years in California in private practice in large community hospitals and also in academic centers before I was lured to the dark side of Silicon Valley. That was many years ago. I've been with Elsevier and Elsevier Clinical Solutions for about a year, and that's who's sponsoring this talk today. And the introduction was appropriate. I'm walking around the hall, my first hymns, because when you're in the operating room, you've never heard of hymns except in Hymns and Hers or something else. There is no hymns, but it's pretty impressive, particularly because I don't know what half of it means. But I'm getting there. What I do know, however, is what goes on in hospitals and in clinics. I've not only been an active practicing surgeon, I've been a chief medical officer, I've worked in a very, very large health system across 10 states, I've been a chief strategy officer for a physician employment group, and now I work in the world of analytics, which I'm still learning quite a bit about. One of the things that I hope I can share with you today, for those of you who are not really from the hospital or office setting, because there are only a few of you, is what really matters to those of us who are actually seeing patients. So with that, we'll get started. Please interrupt with questions at any time, throw things, whatever works for you is fine. So as I learned, you already know the historic use of predictive analytics. For instance, at Elsevier and the competition, we've been in this for decades, and really analytics was something for payers. It's very, very new to providers like me, whether you're a physician or a nurse or a case manager. Analytics are an entirely new concept, but they've obviously been around for many decades, and these are all now becoming predictive analytics solution. Great field, very exciting, particularly if you're a payer, and now as clinical integration is changing, as a provider, I have to understand what the hell this is about, which isn't easy to do because I live in my own world with our own language. I operate all day. I don't have time for this. So what we're going to talk about today is how to get some of this important stuff that payers have used for literally decades into the office and into the hospital. So traditionally, of course, these tools have been used for large populations, enormous amount of data. You look at millions of members, and we look collectively, and we say, let's look at 55,000 diabetics, and let's look retrospectively, and let's put in some processes in our hospitals that can change their care, and then let's look again. So it makes sense. You want to look at large populations, right? What's the best way to take care of your diabetics for quality, to reduce the cost of care? That indeed is why we have guidelines and such, and evidence-based medicine. All of it makes great sense to me. But again, what is that mostly about? It's traditionally been for payers. It's retrospective, looking at large patient populations, and the goal has been reduce the cost of future care. So as a physician, I say, well, what about him? Okay, and what about her, and what about them? It's not really very helpful to understand how to prevent sepsis after she's gotten sepsis, or to understand how best to take care of diabetes when he's already lost a limb to diabetes. So what I'm talking about here is individual inpatients or ambulatory patients, because everyone in this room may not be at the bedside as a provider, but my guess is you've all been in a physician's office as a patient, turned your head and coughed for half of us roughly. So these are the people who also need help, okay? There's absolutely a monstrous role for retrospective-based population analysis, but there's also a role for inpatients and patients coming for their regular ambulatory visits. So how do we succeed in this area? We have to start thinking prospectively, and we have to think about individual patients. And that is an enormous change in the predictive analytics space. So what does it mean when I talk about saying prospective predictive analytics at the bedside? Well, there are a number of critical questions that come up when you think about this concept. First is, what would result from delivering predictive analytics prospectively to doctors and nurses in offices and hospitals across the country? And which providers would we target? Physicians, nurses, physician extenders? What type of predictions? Because I have about 10 minutes a month to talk to you and look at your tool. Truly. I round at 6 in the morning, I'm done at 9 at night, and I'm on call. So I really don't want to sort through 150 predictions, of which 4 matter to me. That's just my world. Okay? And finally, what are the major challenges to bringing predictive analytics to the bedside and into the physician office? So let's start with the first one. What would result? Okay. If you delivered prospective predictive analytics to the bedside and you say, listen, I'm going to bring this in and I'm going to combine it with all that retrospective patient analytics, won't this make clinical integration a success? Because it makes sense that these would help clinical integration, doing them together. But would it actually improve the quality or reduce the costs? It seems intuitive, but it's not always the case. There have been technologies brought into the hospital system to reduce costs that end up costing more. That's happened. That's even happened with CPOE. It's happened with digital radiology. Think of it this way. They used to put breathalyzers in bars to prevent you from driving drunk. How'd that work? Okay, everyone put in $100 and whoever had the highest blood alcohol won. Okay? So it doesn't always work the way you think it would work. We have to actually be very careful when we think about this. So here's what I say. There's something quite unique about healthcare when you look at it just as a provider. If you want a nicer car, you have to pay for the nicer car, right? That's just the rules. And if you decide you want to have a nicer meal, you have to pay a lot more for the nicer meal. That's fine. When you think about healthcare, if you want better healthcare, it actually costs less. I'll just tell you that's true at the provider. If you want my hospital and me to make tons and tons of money, I promise you I'll spit on the scalpel before I use it every time. And so every one of my cancer operations will become an infection and an ICU stay and a readmission, and up till recently, everybody got paid for it. Now, that's just the reality of it. That costs more. But if I do a large cancer operation, we've planned it out, and I use the right guidelines, and I use the right order set, and I have the right people around me, and I have the right data, and I know what's going on minute by minute, or my team does, the patient has very few, if any, complications, goes home earlier, we get to market that, what a great hospital we are, the patient's happy, and it costs a hell of a lot less money. So healthcare is kind of unique when you think about quality. So what would result if we could effectively bring prospective predictive analytics into the hospital or into the physician's office? Well, I do think ultimately it would greatly advance clinical integration, okay? Especially for those people who need help now, especially for those doctors who are seeing people today. The quality of care would increase and the cost of care should actually drop. Everybody should win in this scenario. Well, who are the providers? Well, a long time ago when I was training, there was only one group of providers and you're looking at them. They were the physicians. We ran everything, and it was just like the military. When I was practicing, I remember practicing at a large academic institution, never saw my data, ever, and it was a very advanced. And when someone came to talk to me about some outcomes, I said, not so politely because I'm a surgeon, yeah, last year I billed $2.6 million. You probably want to leave me the hell alone. And the truth is, they left me the hell alone because the CEO of the whole hospital system said, leave him alone, man, he's billing a ton of money for us. That's changed. Not only has it changed that physician providers have to start appreciating this, which is challenging, but the real world is that physicians are providing less and less of the day-to-day care. You know about the patient-centered medical homes, right? So patient-centered medical homes try to take an ambulatory physician, a primary care physician, from 1,500 patients to 4,500 patients. Okay? My practice is supposed to get very busy as a surgeon. How? Nurse practitioners, PAs, all sorts of allied health professionals. So that is who was driving the day-to-day decisions more and more. Even in the hospital, a few years ago there was no such thing as a hospitalist. Now as a surgeon, most of my colleagues rarely see their patient after surgery. The hospitalist does. So the provider group is changing, I'd say much to the chagrin of physicians. We're not the only provider, and you can argue that in many situations now, moving forward with healthcare reform, we're not even the most important provider. There are others who are very, very important. Case managers and discharge managers, when I was training, came by to say, Dr. Edelstein, how long will that patient be in? It's a gallbladder. I'd say 19 months. Okay, thanks for talking. That's not how it is now. They see them every day. They're involved with respiratory therapy, nursing. Okay? Discharge managers, charge nurses, nurse managers. When I trained, there was no such thing as a quality department. Hospitals didn't have quality departments. Okay? I mean, that's strange to think about. But now quality department personnel make decisions on a daily basis that affect patient care. And finally, in the physician group, it's narrowing to hospitalists and intensivists. There are a number of primary care physicians who don't have hospital privileges anymore. You may well have had your doctor for 20 years, see him or her every year, know them completely, and when you go in because you're sick, you never see that person because they don't come to the hospital. So the providers are changing. Well, what type of predictions? Arguably, this is the most important question, because everybody throws out hundreds of predictions as if I would really care about it. I don't. Not only don't I care about many, the ones I care about change. 5 years ago, I cared about urinary catheter-related infections and decubitus ulcers because we were at financial risk for them. Now I don't, because every hospital is taking care of it. So they're 3 or 4 or 5, and they change. The nice thing is it's not a guessing game. CMS tells us. So when the government's ahead of private industry, I get worried. But in this situation, the government tells us what to care about. So all of the predictions that matter to me at the bedside have to fall into 2 categories. They have to be relevant, and we'll talk about that, and they have to be actionable. It does me no good to tell me that Mrs. Smith's going to die 3 days after she passed away. I'm just not that interested. I probably know, okay? And relevant. So what does that mean? It's very crass, but here's the definition of relevant at the bedside right now, because this is what our employers and the hospitals we work in say is relevant. If it threatens them financially, it's relevant. If it doesn't, it's not. And that sounds harsh, and that sounds hostile, but I've both been the provider and I've been in the C-suite, where you can have outrageous mortality for gallbladder surgery, but it's not on the list right now. AAAs are. That's the reality right now. If it threatens someone getting paid, that makes it relevant. So what's actionable mean? Actionable means it has to be real-time or near real-time, okay? Now, when you talk to an arrogant physician, and that may be redundant, I'm not sure, but when you talk to a physician, my answer is, listen, I went to med school, then I spent 7 years in training, then another year after that. I am a predictive analytics machine. I'm supposed to know who's at risk of this and that. That's my job, that's what I get paid for. And to a large extent, that's true, and in fact, I often get information before it gets into the EHR. Because when someone's blood gas or potassium is wrong and is dangerous, they don't go to the EHR, they call me. But as I showed you before, I'm in the operating room. Now the people who have to know are often not the physicians. So they need real or near real time updated information so they can intervene. Okay? And the time has changed. It cannot just be claims data, and we'll talk about that, and it cannot just be clinical data. Why? Well, if you ask anyone who's at an inner city, big hospital, how much clinical data matters in predicting their readmission risk, most of us will tell you about 30%, okay? Because you may come in with heart failure, and I can do everything right, but if you go home and have no car, you're homeless, you're drug dependent, okay, you don't have an address, you don't have a phone, you might get readmitted. So we need both claims data, which includes socioeconomic data, demographic data, and we need medical data. It has to be portable. Okay? There are still many hospitals out there with CALs, computers on wheels, but most of us use tablets or cell phones now, the providers. Okay? And I'm just going to tell you, most of the providers, yeah, we get dashboards. We can handle a little more complexity. I understand the 3 colors. I'd also like trending, okay? Because sometimes a red that's headed the right way shouldn't take my time in the morning. A yellow headed the wrong way should. I'm just telling you honestly, that's how we teach medicine. So if companies come in and try to change that, you're going to fail with us, because that's not how I teach med students, interns, residents, chief residents, fellows, or junior attendings. I talk to them quickly about stratification and trending. You have to see all 40 of my patients. You have an hour and a half. So that's the kind of information that we want in predictions. So what are the challenges? Okay? What are the challenges? Can't we just get bedside providers, be they inpatient or outpatient, be they nurses, case managers, doctors, can't we just get them the same basic information that payers have used for years? Wouldn't that just work? It really does sound simple. It really does. It sounds simple that if I gave you all a book today that showed how to do a large cancer resection for pancreatic cancer, and it shows every single step, that tomorrow you should be able to do it. How many of you are willing? Okay? That's how it feels for the providers in your world. Okay? It's a very, very different culture. Here are the groups. You have the group of providers, though I've never seen a group of us smiling like that, so I know that they're actually actors. You have a group of payers, and it should be easy. except that's the language that they're using, that's the language they're using. And if you want real-world examples, I've been in companies where for the payer side they use terms like chronic and acute and referral, which mean absolutely nothing compared to what I use in my world, which is a medical definition of chronic, acute, and referral. So when you put stuff in front of me that says from an actuary's point of view this is a chronic risk to me, hypertension. So we don't even speak the same language, and that may seem silly, but we actually influence what systems our hospitals buy. Okay? We have to get these guys to all start speaking the same language, okay? Otherwise, it will not work. So that's the first challenge, is just language. This is a bigger challenge. Either directly or indirectly, physicians and to some extent nurses are trained to distrust payers. If it's about saving money, it hurts the patient. I'm not telling you that's right, because it's often not right. That's what we're taught. That's the reality. Claims data, cost data, yeah, I don't want it. I'm protecting my patient. You're trying to screw him with a cheaper implant. So here's what providers tend to think payers only care about. It's all about money. It doesn't matter if it's the right operation. And the payers look at us and they say, yeah, this is all you think about. You'll put in a pacemaker that's meant to last 90 years in a patient who's 87. And I've seen that. I've seen both sides of this. The distrust is enormous, and yet clinical integration is demanding that now payers and providers talk to each other, that they have some trust to each other. Someone asked me recently, why do you think ACOs will sort of be the middlemen, hospitals will be the middlemen controlling ACOs? And I said, from my point of view, I don't trust hospitals at all. The payers don't trust hospitals at all, but I trust them more, and I trust the payers. Clinical integration is going to require not only that we speak the same language, we have to start believing we have the same goals. That is not easy. We are now starting to bridge the gaps, and we're certainly doing it at Elsevier, and I know their competitors doing it too, and I applaud anyone who's going to try to make this reality, because we can do all we want in healthcare reform. If I don't change how I take care of my cancer patient, it doesn't matter. It just doesn't matter. If it doesn't change the way that a primary care physician runs their practice of 4,500 patients, then what does it matter? So what are we doing? We're developing these predictive analytic solutions for bedside and outpatient providers, which use both claims and clinical data. Okay? That's the easy part. This is a little bit more important as the harder part. I taught a group of physicians about 2 weeks ago how to use a clinical integration tool that we have that is 100% claims and cost-based data, 100%. So everything they see, which we are presenting as quality opportunities, is in terms of dollars. Okay? And with due respect, the best person to teach them that that's okay and how to use that is another provider. So I said, just because this is presented as dollar opportunities, what's driving that patient's costs next year clinically, just because of that doesn't mean it's wrong. And we're not telling you it's the only thing to look at. And I understand we're showing you how much this patient is going to spend on valvular heart disease. You know she's a diabetic too. But she's going to spend this much on valvular heart disease and go to the emergency department 3 times and have 9 days in the hospital you don't want. Just because that's claims data, should you ignore that? And when you start talking about it, they go, okay, all right, I understand it. Claims data isn't all evil. It makes some sense, and you're going to help me take care of my patients. So it has to be relevant. It has to be actionable, and you have to understand the cultural differences. Claims data is not all bad. Quality data is not all good. We have to get over that gap. This is one of the tools we're using. We have several tools. Very, very simple tool. It's on a tablet. It's on a phone. It's on a laptop. It's on a desktop. It's real-time or near real-time. It pulls from claims, it has demographic data, and it pulls from the EHR as often as you want it to pull. And this tool was created not with the physician in mind, with the case manager, with the discharge manager, with the charge nurse, with the nurse manager, with the quality team member. Okay? Because at the start of their day, they may have 60 patients to look at. And you say, well, how are you going to spend your time today? Well, I think today I'm going to sort by my inpatient's risks of transfer to the ICU, or my inpatient risk for readmission, or my inpatient risk for sepsis, or mortality, or length of stay. All of these things are customizable, so everyone can do it their way. But it's only a handful of predictions. And they show you the colors you want, and they show you the trending, and you can look a little more closely at them. And you can drill down a little and find how people have trended and what have you. But you don't have to build tables. Because I'm a provider, I don't have time to build tables. I have 60 patients to see. Some of them are going home, some of them are getting sicker. Okay? You don't have to understand what the words mean because they speak clinical. Okay? And the payers are starting to understand that the terms have to make sense to the clinicians. So this is the kind of tool that we're building. Some of them use claims data only, some of them clinical data, and some both. But if you can get these kind of tools into the hands of a bedside provider, and it's relevant, and it's actionable, so real-time or near real-time, and particularly for the non-physicians who aren't trained to evaluate every aspect of sepsis, you can help them become more efficient, intervene, save money, take better care of patients, do a better job. That's the idea. So a quick summary. If we bring prospective analytics that are patient-specific to the hospital, to the outpatient center, put them in the hands of doctors and nurses, and combine that with all of the large retrospective population analytics, that's really clinical integration. It matters to every patient wherever your touch point is. Right? That's a lot of strength. The reality is, I believe the technical requirements are far less challenging than the cultural ones. They just are. Okay? You have the technology. We sell these products. Our competitors sell someone. That's just the reality. The challenge is, how are you going to convince me to use them? Okay? Again, I bill a huge amount of money. I work from dawn till dusk operating. That's my world. I don't speak this language. I was practicing long before you did any of this. How are you going to convince me to do that? And that's the challenge that we have here. And again, I think the challenge is through common language, bringing folks together and realizing we have a common goal, and recognizing it will not happen overnight. So I would be glad to take any questions. The Elsevier booth's around the corner. We have another booth down the hall. But any questions that anyone have?
Are you using your own risk stratification, or are you using ACG?
Right, so the questions are about risk stratification. So we use our own risk stratification tools, a bunch of proprietary tools, that's exactly right. Now on some of our originally claims-based data, which is now for providers, the episodes are ETG groupers and our own risk stratification. Anything else?
I'm curious on your claims. Is it hospital claims, or are you acquiring claims data from everyone and using it as more of an aggregate measure?
So right now it's hospital, but of course the idea is to expand it and get it broader. That's exactly right. The question was, where does the claims data come from? So, well, thank you very much. Enjoy the rest of the show.